Hi, my name is Amy, and I'm a health sciences and physical therapy student. As part of my work for Europe's mini grant and under the mentorships of doctors Annalisa Na and Justine Sevcik, this research focuses on exercise-based pain interventions for individuals living with dementia. To start, dementia refers to a range of complex conditions characterized by a progressive decline in cognition, function, and communication. This can be further complicated and exacerbated by comorbidities, including chronic pain, which, as the literature points out, over 50% of people living with dementia experience. Consequently, poor pain management and the overall pain experience may lead to a decrease in diminished quality of life in this population. We can see this accompanied by disorientation, difficulty in daily decision making and problem solving, as well as decreased participation in social activities and relationships. We can also see an increased burden on their care partners, as well as an increased risk for accelerated institutionalizations for those residing in the community, as further physical and cognitive decline, along with poor pain control, may necessitate a more structured care setting. Now, as we look into the current literature and guidelines on pain management, we find that exercise is recommended as a first line of treatment. However, this does not specify or include those who are experiencing cognitive decline and are living with dementia. Therefore, our purpose here was to explore clinicians' perceptions on the use of exercise to manage pain in people living with dementia who are community dwelling. Now, to do so, we followed a qualitative descriptive study design using conventional content analysis. This is essentially a systematic process of classifying texts and identifying patterns within the data. The data for our study was obtained through clinician interviews and was analyzed through coding and theme identification. To walk you through this diagram, we first purposefully recruited clinicians from outpatient settings that directed their care towards the older adult population. Our clinician criteria included those who had experienced and regularly assessed or treated people living with dementia having pain and provided consent to participate for a recorded interview. Following recruitment, we then conducted semi-structured interviews with them that took place virtually through Microsoft Teams to identify and evaluate their current care practice. The interviews were conducted from trained members in our study team using an interview guide. Then, to analyze and interpret the interviews, we then applied the transcripts into a qualitative data coding software called NVivo. Before coding, we developed a standard codebook to provide a framework to manage and organize the data. This included a detailed description of each code with definitions and examples. From there, members of our study team began categorizing and labeling data in NVivo with the codebook for each interview. Once each interview was coded by a minimum of 3 coders, our study team came together to achieve consensus on the codes that we found. Now, throughout our study, our approaches to achieve trustworthiness included having an audit trail of a detailed codebook that accounted for the initial categories, definitions, and decisions made during our ongoing analysis. Additionally, we had an in-depth review and team consensus regarding our findings that provided investigator triangulation. Now, moving into our results, we had a total of 12 clinicians with a distribution from 4 outpatient facilities. This included physical therapists, occupational therapists, and nurse practitioners. And from analysis, we then found or identified a theme, and a theme emerged itself, that exercise interventions used for pain management among people living with dementia needed to be carefully tailored. So shown in this poster are quotes pulled from the interviews to highlight this theme. We found that clinicians emphasized the need to consider many of the patient's individualized factors. So the first included their underlying pain mechanism. So this included their severity of pain and location of pain. They also took into consideration the patient's cognitive ability so that they can be able to provide more verbal and visual cues throughout their time in therapy. We found that clinicians were also looking into their patient's physical function, such as their strength, flexibility, and endurance, to assign specific exercises. We found that they were looking at safety, so providing more or less supervision to reduce the risk of falls or injuries. They were also taking into consideration the patient's comorbidities and accommodating the presence of other health conditions like diabetes. They were also taking into consideration the patient's preferences, so including a variety of activities that the person living with dementia enjoys to increase their adherence in their programs. Now, overall, this study highlights the positive perceptions that clinicians have with exercise interventions and identified individualized factors that they took into consideration when developing their programs to manage chronic pain of people living with dementia. These findings can guide the updating of current pain management guidelines so that they can become overall more inclusive and tailored to people living with dementia. That concludes my presentation, and I would like to thank you for your time.